syndrome is real and has been puzzling the dental and medical professions for decades. This is the TMJ TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ TMD Demystified podcast.
Welcome, everyone. Good day to you. Glad to have you here. We are gathered for the next episode live stream of TMD Demystified. My name is Tony Urbanek. If you are new to this live stream, this is an opportunity to talk to me, comment, criticize if you'd like, but make sure you bring your science with you. Ask questions for both doctors, but especially the public, especially for the patients, the millions of patients, primarily women. It's 90% females, 10% males. Temporomandibular joint disorder is primarily females for this one reason that is poorly known. It is easily understood. It's in the literature for better than 50 years that estrogen exacerbates inflammation. And what I have discovered, which is also in the literature going back longer than 50 years, is that chronic inflammation in the temporomandibular joint creates each and every one of the disparate symptoms of temporomandibular joint disease. So that little preliminary statement is for anyone new to the channel and watching, because the dental profession has done a very poor job of investigating and using clinical and basic science to address this problem. Orthopedic surgeons know a lot more about this, and if orthopedic surgeons had been left to control and treat the temporomandibular joint, I firmly believe this problem would have been universally solved many, many decades ago. But because the jaw, lower jaw, mandible, is attached to the temporomandibular joint, and the lower jaw mandible is attached to teeth, the powers to be in the medical community and in the orthopedic community thought better of it and said, we don't know anything about teeth, this must be a dental problem. And then it was given to the dentist to figure out, roughly 70, 75 years ago, and it really was a poor area to develop, because the dentists think that this joint is different, and that is what's taught in dental schools. Each and every one in dental schools teach that this joint is different than any other joint in the body, and that just truly is not true. There is where it started. The dental schools looked at this joint, didn't know anything about orthopedics. They knew a lot about teeth, but they didn't know anything about joints. And because it has frankly, a very strange name, guglio-arthrodial joint, meaning it has two motions to it, both a rotation and a translation, guglio-arthrodial, it must be a complicated joint. And we don't know anything about it, so it must be complicated. And that really is where it all started 75 years ago. And as of to this day, it hasn't got a lot better, because today, literally, and today is July 25th, 2026, half the dentists in the United States of America have a night guard made for the patient and tell them that that is their treatment for temporomandibular joint disease. And the other 49.99% of dentists don't want anything to do with treating temporomandibular joint disease because they think it's complicated, which is not. And then there's the very small percentage of dentists that I hold out, and they hold themselves out as specialists, but actually they're TMD gurus using smoke and mirrors and voodoo to try to treat this joint, and at very best try to treat symptoms rather than attack the inflammation in the joint itself. Because it's only one disease. It is a single disease. It's not multiple diseases. It's multiple symptoms. It has many, many symptoms, well known to all of the professions, but it's not multiple diseases. And it goes by multiple names. For example, trigeminal neuralgia is just a catch-all phrase. Trigeminal neuralgia, according to the TMD gurus, is a separate disease. Well, trigeminal neuralgia only means pain associated with the trigeminal nerves, the three nerves, upper face, middle face, and lower face. Trigeminal neuralgia, pain. It's not a separate disease. That is a catch-all phrase, earlier known as tic douloureux. But in any case, if you address the inflammation within the temporomandibular joint and can make the inflammation within the temporomandibular joint go away, decrease, then the symptoms go away, obviously, because the symptoms are driven by chronic inflammation. And that can be proven anatomically, physiologically. And today we're going to talk about that in detail. And today's topic is TMD and headaches. TMD and headaches. As some of you know, I have three directions, three methods that I use to disseminate TMD Demystified. On Sunday night, I spend an hour or so writing a couple pages in a blog that is published on our website and elsewhere. It's also distributed to our list of network providers, doctors who use the correct way to treat temporomandibular joint by unloading the joint with a device and protocol, like a set of crutches unloads a knee. We had to call that protocol and device the Urbanek device and protocol, because the patients wanted to call it miracle device or save my life device. And we are going to be talking about headaches and comparing them somewhat to migraines, which is another catch-all phrase, I believe, and I'll stick by it because my medical colleagues have no idea what causes migraine headaches, and they admit they don't have any idea. They have theories. They know it's associated with the trigeminal nerve system. Some of the theories focus around vascular trigeminal. However, we know with certainty and can prove that inflammation within the temporomandibular joint causes bad headaches that are often confused with and misdiagnosed as migraine headaches and treated primarily with drugs or other methodologies, which is inappropriate if you actually know that the cause of the headaches is inflammation within the temporomandibular joint. So we're going to cover that today technically, anatomically, basic science-wise, and I hope that I can generate from some of you questions or comments. Or again, I'm open to criticism, but make sure you bring your science with you when you're ready to criticize. And of course, explain your terms, because if you are to communicate or argue with me, you must first define your terms. So let's go through, I'm going to share my screen with you, and I'm going to go through a diagram of exactly how inflammation within the temporomandibular joint creates headaches. So hopefully you can see this. I think I made it as big as I can, but I'm going to read through this. So if you can't read it yourself, but I'll leave it up so you can read it yourself if you'd like. First of all, there are three things that actually damage, three characteristics, three methods to damage the temporomandibular joint, because you can't get inflammation and chronic inflammation without damage. And just like any other joint in the body, the temporomandibular joint can be damaged. And as far as I have been able to determine, there are only three methods, three general methods to damage the temporomandibular joint. The first one is the most well-known, the one that everyone thinks of first. I do believe it is the most common as opposed to the other two, but it is not the only one, and that is bruxism, clenching and grinding. Clenching and grinding over a period of time can overuse, abuse, overload the temporomandibular joint, just like you can abuse, overload any other joint in the body. You can damage your knee, you can damage your hip, you can damage your elbow, tennis elbow. Too much repetition of the elbow will cause inflammation of the lateral epicondyle, damage the lateral epicondyle, which creates inflammation. So temporomandibular joint inflammation is persistent inflammation in the temporomandibular joint and surrounding tissues. The capsule, especially the disc or meniscus itself, the synovium and the retrodistal tissues releases inflammatory mediators. Now, when a joint becomes inflamed, the first thing it does, it tries to heal itself. And the inflammatory mediators are the mechanisms, the biochemicals that go on to healing. The second way to damage a joint, as you might think, is acute trauma. And the most common kind of acute trauma that we see, that I've seen, are motor vehicle accidents, especially whiplash injuries. Whiplash is one of the most common types of damaging the temporomandibular joint, and that is because when your neck is snapped back posterior, the mandible is snapped open and can be opened overly wide. And when that happens, you can damage the internal structures of the temporomandibular joint, creating inflammatory mediators, which hopefully go on to healing. And that's the ideal scene. And then the third general cause of damage to the temporomandibular joint is something we call functional malocclusions. Those are not malocclusions when you just have crooked teeth in the front. Those are malocclusions when you have significant differences between the two bites that everybody has. Everyone has two bites. Every person on the planet has two positions of the jaw, two bites. The first bite is where your teeth have learned to mesh together well, with or without the help of orthodontic care, but where your teeth mesh. And sometimes that mesh is good, sometimes it's bad, but the second bite is where the jaw flips back or protrudes back or goes back, where the ball fits in the socket. Bite where the teeth mesh together well is called centric occlusion, where the entire jaw slips back posteriorly and the ball fits in the socket to the best position is called centric relation. And everyone has a difference between those two bites, everyone. If it's a small difference, the patients can accommodate it well and they never even know that they have two bites. If that difference between centric occlusion and centric relation is significant enough, then they have a functional malocclusion, and a functional malocclusion can cause damage to the temporomandibular joint. And those are the three reasons where you get inflammation within the temporomandibular joint. And when the joint becomes inflamed, then you have the inflammatory mediators trying to heal. But when they don't heal, when the inflammatory effects go on too long, the cellular types and the mediators, or the cellular exudates from those inflammatory cells, change into what we call chronic inflammation. And chronic inflammation does something totally different than traditional early inflammation. Early inflammation has healing characteristics, and chronic inflammation has damaging characteristics to the point where the bone and the tissues themselves begin to degenerate within the joint. And this goes on in hips and knees and elbows and temporomandibular joints. So when the chronic inflammation does not heal completely, when the inflammation does not heal completely, the chronic inflammation takes hold and starts to damage the inside of the joint. Now, the mediators themselves, chronic inflammation then, sets off a circular set of stages. And the first one is the autonomic nervous system sympathetic portion mediators stimulate the sympathetic afferent fibers in the temporomandibular joint surrounding the tissues. These afferent pathways go to the brainstem. Autonomic, we don't know about this. This autonomic nervous system is the same nervous system that runs your breathing apparatus in your heart. And these afferent pathways through the trigeminal nerve go to the trigeminal spinal nucleus and the brainstem. I think you can see a diagram of that. And at the brainstem, it then integrates with the autonomic sympathetic efferent output, and the brainstem integrates the input and sends autonomic sympathetic efferent signals, meaning away from the central nervous system brainstem, signals to the muscles of mastication via the descending pathways or the nerves of the autonomic nervous system sympathetic portion, through the preganglion nuclei, to the superior cervical ganglion, through the postganglionic fibers, and then the muscles of mastication. So now you have efferent fibers stimulating the muscles of mastication to tighten up. What the central nervous system is getting, it's getting these signals, the joint's inflamed, I'm going to help you out. Don't move the joint. Tighten the joint. Don't move the joint. And the muscles of mastication tighten up, and wherever those muscles of mastication are inserted into the facial structure, the bones, the periosteum, the coverings of the bone of the face. It can be the jaw, can be the middle face, it can be the upper face, where the temporalis is really the most common point where patients present and say it hurts right there every morning, where that big fan-shaped muscle, the temporalis muscle, is inserted into the top of the skull. Or it can be under here. Or it can be the masseter muscle, both the origin and insertion of the masseter, the origin and insertion of the temporalis, the origin and insertion of the mylohyoid, the origin and insertion of the external and internal pterygoids. And all those muscles, when they get tight, they'll pull on the bone, they'll pull on the periosteum, and stimulate the nociceptors. So the muscles of mastication contract, sympathetic activation causes increased muscle tone, guarded contraction, and spasm of the muscles. And the result is trismus, limited mouth opening, and pain. And as I said, that's step 5, stimulation of the periosteal nociceptors, sustained muscle contraction, and increased intraosseous pressure stimulate postosteal periosteal nociceptors, which are the pain receptors, on the bone surfaces of the mandible and maxilla and craniofacial structures, at which point then the patient will complain of facial pain, which sometimes moves around from one point to another. It never stays in the same place, which is quite disconcerting to the physicians because they don't understand it. If you go to the physicians and say, I have headaches and earaches and upper back pain and ringing in my ears, the physician says, that doesn't make any sense to me. That symptom complex doesn't make any sense. And if they are suspicious, if the physician, the PCP, the physician's assistant or nurse practitioner in the walk-in clinic, you walk in and say, I have terrible migraine headaches, Well, they may prescribe you some drugs, or they may say that doesn't make any sense, all these different symptoms. But the point is, the physicians don't know anything about it, and if they suspect it, the only thing they can say is go to your dentist. And the dentist, as I've already repeated, 50% of them make a night guard, hoping the patient doesn't come back, because the dentists are aware that night guards don't affect temporomandibular joint disease. That is a fact. They know night guards aren't effective. And then 49.99% of the dentists don't want anything to do. They say, I don't do that. Actually, most of those doctors will say, go see your oral surgeon. They're supposed to be the smartest guys, so go to see the oral surgeon and see if he can help you. And then we have our TMD gurus who use smoke and mirrors to treat symptoms, hook you up to myofunctional devices, use Botox, which just paralyzes muscles temporarily and doesn't address the common denominator, doesn't address the cause, which is temporomandibular joint inflammation. So it's very, very simple. Very, very simple to understand why it is one disease. And let me see if I can then talk just briefly about why treating it the way we treat it and the way you treat it correctly is to unload the temporomandibular joint. You unload the joint according to a protocol. You can't do it just any old way. You do have to be careful. There's very limited ways you can make this worse, truly, or create a problem, an unintended consequence. But let's go through this. So 15 years ago, after doing 2,000 temporomandibular joint surgical cases on the joint, temporomandibular joint, I decided not to do any more temporomandibular joint surgery because the patients would be back, or a third of the patients would be back within a year or two with the same symptoms. 2/3, we did pretty well with those. A third, they'd be back. But those statistics were not good enough for me. And I decided to do the research to try to figure out what was really going on about this disease. Because at that point in time, as it is now, I knew that half the dentists were making a night guard and half the dentists didn't want anything to do with it because it was a complicated problem that they were taught nothing about in dental school. So I did the research, and it turned out to be quite simple what the mechanism was, which I just explained, and it became, once you understand the mechanism, it became quite simple of what to do about it. And what to do about it is just unload the joint like an orthopedic surgeon would unload a knee or an elbow if there's chronic inflammation there. And the best way to treat tennis elbow is to put the patient in a sling for a while and just rest the joint. Like the brainstem is telling the muscles to tighten up. Rest the joint. Hold the joint motionless. So you hold the joint motionless with a device that separates the posterior teeth. 90% of the loads on the temporomandibular joint are created by the function of the posterior teeth. The anterior teeth only allow 10% of the function. That's because of what we call proprioceptors. Proprioceptors are actually in surrounding the roots of the teeth. That's why you break nuts with your back teeth. You don't crack nuts with your front teeth. You have to crack nuts with your back teeth. And that's because the proprioceptors and the proprioception of the teeth themselves does not allow you to put that much pressure on the front teeth. So you have a device that you wear according to the protocol, and the protocol is simple, 24/7 for 2 months, then nighttime only indefinitely the rest of your life. And for the doctors out there, there is no need to worry about super eruption of teeth in the first 2 months in adults. You do not see super eruption of posterior teeth in adults in 2 months. The patient certainly has to take the device out of his mouth to chew, but you can drink with it in your mouth, you can talk with it in your mouth. You obviously have to have something that you can talk with in your mouth if you're going to wear it full time, 24/7. And then you, after a 2-month period of time, then you transfer transform into using it nighttime. And that is how it works. So we'll just read these steps. First of all, step one is to use the device, which sits and is maintained in the upper portion of the jaw, behind the upper teeth. Then that unloads the mechanical stress, is removed and unloads the joint. The mandibular condyle is no longer compressed against the articular disc and the retrodiscal tissues. Number three, inflammation decreases and resolves. Step four, there is reduced anatomic sympathetic afferent input because now the inflammation has decreased or resolved. The brainstem then doesn't get the efferent signals, and the brainstem does not stimulate the neurons, and you get decreased sympathetic efferent output. Step six, then the muscles of mastication relax, and the periosteal, step 8, the periosteal nociceptors are no longer stimulated, and when that happens, you no longer have pain. You no longer have headache. You no longer have the muscles pulling on the bone, creating the pain, different parts of the face. And we have the guru doctors trying to distinguish between each of these areas of the face as a separate disease. It makes no sense. It makes no sense at all. So that is the value of using a proper device and using it correctly according to a protocol, and using it with oversight from a doctor who understands the mechanism. Of course, this device is patented and it is FDA approved, and we have our own independent university studies proving what I just went through for you. So I encourage anyone who'd like to make a comment or question to do so. I encourage you to think about this yourself and see if this doesn't make sense to you, whether or not you're already schooled in the basic science, as a dentist should be. A dentist going to any dental school in the United States of America should have a strong background and training in the basic sciences of anatomy, physiology, some cell biology, biochemistry, and for those of you who have, this will make perfect sense as to how the proper mechanism of temporomandibular joint disease operates. It's one disease, not multiple diseases, which is proposed and propagated and taught in many universities at this time. I don't understand it. I truly do not understand why they do that. With that being said, I think I've gone through the entire information that I wanted to share with you today. Again, I hope it's helpful. I hope it stimulates you. I hope that you have reason to apply this to the thousands of patients, if you are a dentist, that you see or can see and resolve their issues, or if you are a patient or a person with these symptoms, I encourage you to seek out proper treatment. Our practice and related practices are now in 20 states in the United States of America. You can see the other doctors in the United States who use this device, the Urbanek device and protocol, on our website, www.urbanek, URBANEK, TMJ.com. And if you can find a doctor near you, I strongly suggest you ask for a consultation. And if you are not in an area, I would strongly suggest you ask your dentist to go to www.urbaniktmj.com. Maybe listen to this podcast, listen to this live stream, which is being recorded, and see if it doesn't make sense. And your dentist can learn how to do this just on a 3-hour online course. Or you can come to Nashville and take a course we offer quarterly in Nashville, or and take the course online, but you have to be schooled, you have to be educated somewhat and get away from treating symptoms and learn how to treat the actual cause of temporomandibular joint disorder, which is chronic inflammation within the temporomandibular joint. With that said, I don't see, we have several in the chat box, excuse me, we have several in the viewer box, but I don't see anyone in the chat box at this time. If there are any questions or comments, again, I'm open for questions, comments, and even criticisms, but make sure you be able to bring your science with you when you'd like to criticize. I want to solve this problem for the millions of women who have it and have been run around in circles for decades with this problem and go from doctor to doctor hoping to find a solution when the solution has been right there in front of everybody's face for over 50 years. The dental establishment, the dental profession has gone down a dirt road just trying to treat symptoms rather than actually addressing the cause, which is inflammation leading to chronic inflammation which within the temporomandibular joint, which leads to all of these facial pains, including headache, earache, jaw pain, neck pain, tinnitus, ringing in the ears, subjective hearing loss, which is that fullness in the ears, dizziness, vertigo, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness. And we have painful symptoms, which are, I just explained, and the 3 non-painful symptoms, which is a totally different mechanism, which I have explained and will explain again at some time in the future on this live stream. But the non-painful symptoms are tinnitus, ringing in the ears, subjective hearing loss, fullness in the ears, and dizziness, vertigo. All right, with that is a full explanation of the symptoms. We'll just leave it there. I look forward to the next opportunity to speak with you, next opportunity I have to answer questions, which will be next Saturday at noon on TMD Demystified live stream. I am Tony Urbanek.